liver disease. So obviously Paul and Vinay Sundaram from Cedars and Arpan Patel from UCLA and Liyun Yuan from USC. And then of course Suzanne, who's hopefully virtually here.
I'm here. Can you hear me?
So do we have some questions from the audience? Yeah, go ahead.
Maybe you could repeat
Suzanne.
my question. For Dr. Palmer, is the PET data is quite intriguing, that we have a PET scan that could identify HCC. Is the choline 11 specific just for liver cancer? And do you foresee that it will be used if it's diagnostic for HCC to be done also as a staging at the same time?
I will, oh, sorry, I've got an echo on mine. Can we talk without my earbuds in just because of the echo? As far as the C11 choline, the data that, I'm not an expert on this, and I got this from Dr. Jadbar Hussain, and this is something that is just being evaluated for multiple tumors. The only data I know is what I told you on HCC, so I apologize for not having that information. The use for it in screening or workup, initial workup for hepatocellular carcinoma, it might be helpful or could be helpful for those early or well-differentiated HCCs. How much it will be added to the workup is it's hard to know. So obviously I don't have enough information to answer your question, so I apologize on that.
Okay, thank you, Suzanne. I have a question actually sort of related to HCC, and that is, we often get referred patients who have liver lesions who don't have any obvious liver diseases. And I was wondering if maybe Suzanne can comment on the utility of OPTN and LIRAD's criteria on people that don't have known liver disease, or we think probably don't have underlying liver disease, because sometimes we come back with these LIRAD's lesions in people without liver disease and how it applies to those patients.
Yeah, I think that is a conversation that everybody has in their own institution. And the problem is that when, even for HCC, as we were told, the follow-up and treatment of hepatocellular carcinoma is not uniformly used across the board in all patients. The thing that is great about these RADS categories, whether they're BIRADS for breast, TIRADS for lung, PIRADS for prostate, the real strength of these things lies in what happens when something is graded or given a LIRADS number. It's very straightforward for breast because it's breast cancer, no breast cancer. Prostate, it's a little more gray area, but it's cancer, no cancer. What is the number that triggers a biopsy? For LIRADS, because the liver, and this is my perspective, and if you go to anybody out of UC San Diego, you're going to have a different perspective. My perspective is that there are many of these benign lesions that, we could call it a meningioma. We don't have to call it we could say it's a LIRADS 2, but I can tell you it's a meningioma. HCC, we diagnose HCC on imaging, certainly, but those indeterminate lesions, what are we going to do with them? Are we going to biopsy them all? Are we going to follow them all? Are we going to have sort of the gut? I don't know what it is, but I think it's benign. There's no LIRADS code for that. There's just so much heterogeneity in the liver lesions and little structure of what to do with those lesions in terms of following up. So when something like LIRADS is put into place, there has to also be something for follow-up. What do you do with that number? And I don't think we're quite there yet.
The question.
Yeah, just one comment from yesterday's series and one from today. I come from an infectious disease background. I'm probably your token ID person here. So in terms of hepatitis B, the drug adefovir came out 15 years ago. It was for HIV, was very toxic, but it controlled hepatitis B very well with very small doses. Viriad came out for HIV, also worked for Hep B, but no one's done the study with using small doses of Viriad, which is now generic. Patients should take a quarter pill of Viriad for Hep B control and control it very well. So in terms of getting the cost of Hep B therapy down, which is one of the goals of a talk yesterday, has anyone looked at using Viriad broken in smaller doses to control Hep B to get the cost down?
I can address that. There has been a study of Viriad every other day in patients with creatinine clearance or a GFR less than 30. And it shows no fall off in efficacy. So, and I can tell you anecdotally, I have a number of patients that, in order to save money, went to QOD dosing of their Viriad once they were DNA undetectable, usually small frame females, and they all did fine. I don't think anybody's gonna, but I know what you're asking. Is somebody gonna fund a formal study?
Gilead won't fund it.
No, they're not gonna. Afraid not. So, but
Anyway.
it might work.
I mean, its potency for Hep B is much more than for HIV, so much lower dose seems to work. The other comment was out in this era of reaching patients for follow-up, it was the era of telemedicine, which all of us are doing. Is anyone like calling these Hep C, these cirrhotic patients with a phone call every 6 months to talk to someone about coming in and be screened as opposed to letters and mails which get lost in the mail? I mean, phone calls, and we've been doing it now for 2 years because of COVID, and phone calls are much more efficient. They like talking to a doctor, and it's relatively quick, so just something to consider.
Somebody want to take that?
Yeah, I think definitely we need a campaign to improve HCC screening. Like we're doing like mammogram for women every year, right? And about 40, for a cirrhotic patient, and those patients really need HCC screening and every 6 months along with AFP. I do think, really need a campaign from primary care physician and the hepatologist, and get them on the top of their scheduling, and we can capture the cancer at an early stage and get treatment for them.
Arpan, at the VA, how do you handle that?
Yeah, I think that's a really great point. I do agree with Dr. Yuan that forming effective partnerships with primary care teams is going to be our approach, I think, moving forward in whatever health system we do, because we have all this talk about improving diagnostics, Gallup score, but even the rates of HCC screening are 30%, even if you look, improve it to 12 months of surveillance. So clearly there has to be, to get to rates like mammograms or 70% in breast cancer screening, we need to change the approach of not just having the onus fall on hepatologists, but having primary care teams also, and maybe improved surveillance or improved strategies will help primary care teams in doing that, but I think that will be our approach. And that's what we do at the VA. We try to get primary care teams to get involved in it.
Possibly, the radiologist only gets reimbursed if they touch bases about the kidney, the aorta, and a number of other issues. And so even though you go and you want 90% of that ultrasound to be spent focused on the liver, that doesn't happen to have the radiology division get reimbursed for their procedure that they've done when you're just doing this specifically for liver imaging. Correct me if I'm wrong, but I believe that's the case.
It is true when you're doing imaging for anything, for like ultrasound in the abdomen for a liver mass, that if we don't have images of all the other organs in the upper abdomen, we don't get reimbursed. However, having said that, it's a full, within a good experienced ultrasound person, doing the entire abdomen can be relatively easy, or not easy, but it can be done relatively quickly while still focusing on the liver. Obviously, every institution is going to be different. Coming from USC, I'm used to having very, high quality liver imaging, and we get the entire abdomen at the same time. Other places, you can't depend that will happen. So yeah, there is that billing. If you're at the VA though, not a problem. And actually, can I just comment on the choline question? Because one nice thing about being stuck at home with a bad back and a heating pad is that I can actually look things up. And the choline tracer for PET tracer initially was being used for prostate. And they were noticing that there were lesions in the liver, and some of those were hepatocellular carcinoma. So they decided to do more studies on hepatocellular carcinoma. The problem with hepatocellular or choline with initially diagnosing hepatocellular carcinoma is that there is quite a bit of overlap of precancerous with early HCC. So as far as the question of using it for diagnosis, probably will not be used because of that overlap.
Callie, you have a question?
Yes. Okay. So I had a quick question about the GALAD score and how you're practically using it in clinical practice. So is it being used in place of AFP with the ultrasound every 6 months? Or are you getting the GALAD and then depending on that score, deciding whether or not to proceed with cross-sectional imaging? Second question is if anyone's using L3 or DCP in the transplant setting among patients who are diagnosed with HCC. Thanks.
I didn't hear the second question.
I-
Or DCP in the transplant setting.
Okay. Well, you want to?
Sure. So the question was two parts. I think one was how we're implementing the GALAD score and whether it's being used in place of AFP. And then the second one was whether we're implementing GALAD post-transplant. So
during the transplant process in a diagnosed HCC patient.
I'm sorry?
Among patients who are diagnosed with HCC in the transplant setting, is it being used to?
Oh, okay. All right. So I'll answer the second part first. For patients who are on the waiting list who have HCC, we are not using it. We are using the alpha fetoprotein, and that's primarily because based on UNOS requirements is that they need an AFP level of less than 500 to get MELD exception points. So it's primarily driven by AFP. And furthermore, if they already have a diagnosis of HCC, even if they've received local regional therapy, they're going to get Q3-month monitoring. That's how we do it. So it's not as if you are, you're monitoring them only Q6 months. You're getting Q3-month cross-sectional imaging as well. So they are getting pretty good monitoring. In terms of implementation in the general practice, we are using it. Quest Diagnostics now has this available, so it is, it's commercially available to get, and we are using it in place of the AFP. So traditionally, I get an ultrasound as well as the combination of AFPL3 and DCP, and then the GALAD model can be easily calculated, and that will help to determine if they're higher risk. If we should do cross-sectional imaging. Traditionally, if they do not have a lesion on their ultrasound at that moment, I will not get cross-sectional imaging immediately unless there is really a red flag, but I will get cross-sectional imaging the next time around at that 6-month time point. I'd be interested to hear what other people have to say.
We use the AFPL3 as well in the non-transplant population, and it's sort of hit or miss. So I think we would do a better job if we did this in a regular, regimented fashion and ordered the GALAD score on everybody. I don't know what kind of insurance pushback we would get. But my guess is we could save enough money on cross-sectional imaging that it would be cost effective. I mean, an MRI, an MRI at Cedars costs as much as a house in San Diego. Come on. And parking costs as much as the whole appointment in San Diego.
It's true. That's why they all get mad at me.
So, I mean, But even at Scripps, MRIs are really expensive. So, I mean, we're doing these, in the transplant population, I get it. But it's hard to justify it in the non-transplant population. And so it would help maybe, and it probably would be cost effective at the end of the day, but I'm not sure how payers are going to handle it. If anybody has any view on that.
VA, are you guys using it?
We're not, at the VA, it might be implemented differently at all centers, but at our VA, we're not using the GALAD score or ALPL3 or DCP, but we've been more focused on ways to improve uptake of ultrasound in the AFP.
It'll be interesting to see if, UNOS requires it in some fashion related to people either with HCC, non-HCC, or meld exceptions and things.
Yeah, I definitely think it will be very interesting question in the future too, because UCSF have all these AFP, monitor the number of AFP, in coordinate prognosis, exclude the patient from exception. I don't know how they coordinate with GANA score and re-justify, who have more aggressive cancer, how we move forward for transplant. And there's a lot of issues. And I definitely think, having GANA score, because we definitely recognize the issue for HCC screening and have FP, ultrasound sounds it's not good enough, have more sensitive marker to capture the specificity and sensitivity in coordinate ultrasound, because ultrasound is so technique dependent too, and then you have ultrasound at USC or you have ultrasound at community hospital, it's very different and they have very different quality, and have both, to help, to capture the patient with cancer. And I do think it's very important. It definitely we're coordinate into our practice in the future.
I want to caution people though, for DCP, if somebody's on warfarin or is vitamin K deficient, you need to be very careful because you could have a DCP of 3,000 with somebody on warfarin. So, I have one question from the virtual, if that's okay, for Suzanne. Is contrast enhanced ultrasound safe in pregnancy?
Sorry about that. It's still a Section C drug. So we say that we should not use it in pregnancy. Yeah.
Actually, that's a really good question, though, because I must say I've made the mistake before in patients with adenomas who are pregnant of getting an AFP, and then it's high, and I'm like, okay, So it'd be nice to have something that at least makes me feel better when they're like, have 3 months or 4 months left in their pregnancy, and I don't want to give them, other contrast.
Yeah, and it's always a risk-benefit analysis. Certainly, if it's in the first trimester, the decision is completely different from when they're in the third trimester, when you usually can push to post-delivery.
Just a question of our comment about insurance. As I see it, a lot of times when I order an AFP in a patient of Medicare age, it is denied, or the patient has to play what's called an ABIM, that Medicare will not cover a simple AFP in the diagnosis of just plain cirrhosis of the liver. For certain things, if you've got hepatitis C now, it will be covered. I've tried to appeal to the New England, the New Hampshire life insurance company that evidently Medicare relies on their data, and they won't respond. Has anybody else had that problem, or do you look at it?
Yeah, we've had it. We have to have them sign a denial. Yeah, in case it gets denied, they're going to pay for it. Right.
Why doesn't the society, not the society, but our liver organizations petition Medicare for that?
Yeah, well, I think the bigger issue is going to be AFP is not really an expensive test, but when you start getting AFP, L3, and DCP, that's going to be expensive.
Yeah, actually recently the ASLD Practice Metrics Committee recently published the quality indicators for HCC. So those are actually instrumental in getting Medicare to reimburse for certain quality measures, which they have for cirrhosis. So hopefully actually in the next year, they probably will, probably update their metrics and improve reimbursement from Medicare.
Okay, Wally, do you have another question?
Just a quick comment, just to follow up on the GALAD score. Dr. Judong Yang from Cedars published a nice study from 2 years ago about the utility of adding GALAD score to the ultrasound. And it shows an increase in AUC under the curve from 0.8 to 0.96. So for clinical practice, as you mentioned, community ultrasound is different than ultrasound done at an academic center. So combining the ultrasound with a suspicious mass and a GALAD score hopefully will lead to increased detection or suspicion for concerning liver mass and referral to appropriate people to manage these lesions. So you want underdiagnosed liver cancer. In other words, will increase the detection of liver cancer.
So who published that? Who was the first author on that?
Yang, Judong Yang with Roberts.
Great, thank you.
I have a question for the panel actually regarding transplant. This comes up a lot. So, Suzanne and her colleagues read that there's an OPTN 5B lesion and a bunch of either non-OPTN lesions or, suspicious but not diagnostic. And then we're trying to make decisions about, should we transplant this patient? So, a lot of times these patients are fairly decompensated. There are 5 or 6 lesions. We're not sure what they are. And then we transplant them and we talk about, well, we're worried, and then the liver comes out, and sometimes we're like, well, we kind of expected this, and sometimes we're like, oh, it wasn't HCC. And I'm wondering how maybe some of the other programs handle these sort of indeterminate lesions in people with known HCCs.
Yeah, it requires an extensive discussion in our tumor board. I mean, this is a problem which we don't have an ideal solution to. Typically, if they're sub-centimeter and they have the appearance of a regenerative nodule, we tend to trust our radiologist on that. Obviously, the tumor marker is useful in that situation as well. Obviously, we also make sure that they get full scans, chest CT, bone scan, et cetera, to make sure there's no evidence of extrahepatic invasion. But I think it just requires an extensive discussion with radiology in a multidisciplinary setting.
Yeah, sometimes we also because we definitely have many indeterminate lesions, look at the history of cancer and biological behavior, and along with short interval, follow-up to see whether the lesion has changed. And as the Kahn note, there's also could potentially intrahepatic, cholangiocarcinoma or combined HCC and cholangio, some atypical lesions. And when they're large enough, we may need to have to biopsy to see whether the patient have involving cholangiocarcinoma and no longer a candidate for transplant.
Carrie Frenette's not here to speak to this, but she instituted this in our tumor board, which is that all cases presented at the tumor board, and there's, they have tumor board every week, and they have 10 cases, and probably half of those are new. So all cases that go to transplant, then the tissue gets presented, the explant gets presented by the pathologist at the end of tumor board, and they remind everybody, okay, this is what we saw, this is what the recommendation was for tumor board, blah, 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 and this is downstage and blah, 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 and then they show the dirty laundry. So it's really been an awakening process, and I think we've all learned from it how much stuff we miss.
Right.
So.
And following up on transplant, I'm just wondering about your post-transplant HCC surveillance. I remember I was at a meeting, ASLD HCC sort of consortium kind of meeting, probably 15 or 20 years ago, and so many arguments about how long to image and how to image and when to image, and I'm just wondering what the thoughts are. Some people use the retreat score, and I'm just wondering how the panel feels about post-transplant surveillance.
We have a very different setting at the VA, obviously. We have about 80 patients who follow post-transplant, but I think there has been interest in us implementing the retreat score, which came out of UCSF from Neil Mehta's group, because also the fact is that a lot of patients don't want to, especially those who are traveling from far away, don't want to get MRIs every 3 to 6 months. And so I think, at least doing a risk stratified approach makes sense, like with the retreat score.
Vinay, what are you doing at Cedars?
Yeah, sure. So we are just kind of, we are not risk stratifying, just except for the presence or absence of microvascular invasion on the explant, then that would, that increases risk of recurrence in our opinion. So in general, anyone with HCC, yeah, they are asked to do cross-sectional imaging and AFP level every 6 months. We're doing that for 4 years post-transplantation. If they have microvascular invasion or they were determined to be outside Milan criteria based on the explant, obviously they would have been inside for us to have gotten exception points, then we are screening them every 3 months for the first year, and then it's transitioning to every 6 months.
And Paul at Scripps?
Agree.
Yeah, I think USC, we are kind of doing the similar, and as you know, like we also look into explanted pathology, and to see, because there's, Connie actually published several abstracts regarding this disparity. There's explant pathology and pre-transplant, there's incoordinate, about how many tumors in the explant, and which very surprising, and not all patients got transplant, but they have much more tumors in the explant, but not captured from CT scan. So based on explant pathology and whether there's vascular invasion, and we kind of grade high risk for recurrence. Those patients will work at CT surveillance every 3 months within a year, and then we space out for every 6 months. But again, I think we're doing a really good job, and to transplant HCC, maybe derived from a UCSF group. And they're very strict screening for mere exception. So I published the abstract with my resident in ATC last year to abstract. We actually, the recurrence rate surprisingly is very low.
And how many years post-transplant are you doing the screening for?
Yeah, and so for high-risk patient, we do up to 5 years, and for no-risk patient, we do 3 years, yeah.
But the retreat score, interestingly, this recently came up. We had a patient who had, I think, maybe a 3-4 centimeter lesion, went for Y90 and was transplanted like 2 weeks later, had an AFP of about 5, and almost 100% necrosis, actually 100% necrosis. And the question was, the patient would have a retreat of 0, which would mean no surveillance. And the question then comes up, of course, if you have a lesion that's there and you treat it, and yes, it's not there anymore, but that doesn't necessarily mean, of course, that there isn't some micrometastasis before transplant or perhaps during transplant. So, I think we have to sort of look at the patient and take other features into account as well. So there's one last question. This is from the virtual, which is probably for Dr. Yuan, and others can comment as well. It says, please comment on your experience with living donor transplant. And I'm not sure if that's in the context of HCC, but I suspect it is.
Yeah, I think, we talk about a lot of transplant and transplant for acute alcoholic hepatitis, or QT, circle, and also the abstract has presented, fewer transplantation for HCC exception. And that comes, we recognize how we can expand in our donor, for HCC patient, for the patient who actually, right now we kind of deprioritize patient for HCC and transplant for HCC with median MEL -3. We all notice as a transplant hepatology, and in this particular region, very competitive high MEL score, and organ goes for acuity in the high MEL score patient, and HCC patient actually was left behind. So we actually really encourage living donor transplant for those patients. And I think, of course, there's a lot of way to expanding like donor pool, and living donor actually is really good way to expanding the donor pool for those group of patients, yeah.
And any other comments?
I mean, I have very little experience with living donor. We don't do it at Cedars-Sinai.
We don't do it.
At VA, we have one center that does living donor, which is Pittsburgh. So we would, if patients are interested in living donor, if they ask about it, which is very infrequent, I'll usually talk to our colleagues at Pittsburgh about it.
I will say in our region, we've been transplanting much less HCC during the last few years, I think because of changes in allocation, and we've been, I think, doing more living donor HCC than before. But what I will say is if a patient isn't a candidate for transplant, they're not a candidate for living donor transplant. So there's sort of a perception patients come with their 20-centimeter tumors and their donor, and unless they otherwise meet criteria, they're not candidates. So it's a way of getting somebody a transplant in a timely fashion who otherwise should get a transplant. So any other questions? I think it looks like that's about it. So I think we'll just wrap up. So I would need to remind everybody about doing the post-test, filling out the forms for CME and MOC, and then next June 10th through the 12th, Dr. Sundaram is one of the co-chairs of the summer meeting in June. That's going to be, I think, again at the Ritz-Carlton. So thank you, everybody.